I'm Dr. John Kruse, and today I'm going to be talking about antidepressant withdrawal. And I'm speaking specifically of serotonin reuptake inhibitors and serotonin and norepinephrine reuptake inhibitors. So Paxil, Prozac, Luvox, Lexapro, Celexa, Effexor, Cymbalta, Fetsima. So these are far and away the most widely used antidepressants. I'm not going to be talking about monoamine oxidase inhibitors or tricyclics. Do have some potential more serious dangers from withdrawal. And I'm not going to be talking about Wellbutrin, which is in a class by itself, which is not immune from withdrawal problems, but it's quite uncommon with those. So to the SSRIs and SNRIs, is withdrawal a big deal? In my training years, I was taught pretty close to what the national boards were saying, mental health boards, and essentially not a big deal. And there's been a big push from people who have lots of qualms about how widely we are using antidepressants in our society. And we should be asking and looking at these questions. But a fairly large meta-analysis came out in 2019 by Davies and Reed. Their claim was almost the opposite, that withdrawal is really common and it's severe, and we need to be taking this into account when we are prescribing these drugs. My own clinical practice over the years, I've worked with hundreds of people who are on antidepressants. I didn't believe it was a success for many of them when I helped get them off of the antidepressants. And with a few exceptions, I may number less than one handful, I would classify all the withdrawal issues as either non-existent, very mild, very curtailed in time, and not serious. I can think of the exceptions where a woman who came to me who had been on Paxil for more than 15 years, Paroxetine. Her previous doctors had tried to taper her off of it, fairly rapid taper. She had horrible GI distress, constipation, developed prolapse of her rectum, and was on paroxetine and terrified of being on it. We went through a very, very slow, gradual taper, and she's doing much better for the last 4 years on escitalopram. And given her extensive history of both depression and anxiety, both she and I believe, and believe that the data supports, that it does make sense for her to be continuing on that indefinitely. Had a handful of other people. So the other worst outcomes I've seen or withdrawal issues were related to taking Effexor, one on Cymbalta, who were just missing doses. So we're not intentionally planning to stop, but missed doses. One who had weird tingling around their fingers, mouth, and didn't even put together that it might be related to missing their Effexor. Went to the ER. Actually had panic attacks in response to what was going on with her body. It took a few days before she actually called me, and I asked right away if she had stopped the Effexor. I had another patient who, a year after I stopped working with them, abruptly stopped the Cymbalta against what I had counseled at length, and felt extremely terrible, suicidal, dysphoric, and also had an ER visit because of that. So again, my own experience doesn't support the claim. Commonest withdrawal symptoms are a flu-like picture without the fever. So it can be nausea, it can be muscle aches, it can be headaches, it can be just general malaise, feeling lousy, it can be gastrointestinal distress. Most commonly shows up, depends a little bit on the half-life, or a lot on the half-life of the agent involved, but usually 1, 2, 3 days after stopping medication. And again, it can go on for several days, in my experience, or what I usually see commonly. But usually, even if there's no interventions, does usually resolve within several days, a week or two. Certainly, getting back on the medication that you were stopping, particularly if it was an inadvertent lapse, almost always within hours gets rid of those withdrawal effects, helping confirm those were really withdrawal effects. Other common SSRI, SNRI withdrawal effects are insomnia. So an overall state of agitation and arousal. Emotional lability, so emotions can come up much more quickly and be flooding and powerful. And one particular aspect of that is many people on SSRIs have difficulty crying, or their crying is inhibited, and often as part of that withdrawal syndrome, they're crying at the drop of the hat at things that wouldn't normally feel that would perturb them, and fairly often are crying in situations they don't even feel or aren't aware of feeling that emotionally upset. Really distinctive and associated with SSRI and SNRI withdrawal is a sensation of brain zaps. That's the common term that people who haven't even heard the term before most often will come up with. People feel it or describe it as a sensation often at the base of the neck, sometimes other parts of the spine, sometimes traveling, but a sudden shock, like a static electricity shock after you walked across a carpet, but it's not painful, just a sudden jolt. That can happen once or twice a day, can happen many times an hour, can appear in some other situations, but far and away if someone's describing that, first thing to think about would be that they stopped or withdrawn from their SSRI. Half-life of the medication does have some role, a big role in how soon you might see withdrawal effects. Clearly, the SSRIs and SNRIs do not have withdrawal effects at the same rate. So Prozac, which lasts a very long time, half-life is about 10 days on average half-life of its active metabolite, nor fluoxetine. You can miss many days in a row, your blood level isn't dropping appreciably for several weeks. So fluoxetine withdrawal syndromes, if they happen, are likely to occur many weeks, months out, not immediately. On the other end, Effexor and naproxen has a short half-life, and many people on Effexor, particularly before we had extended release Effexor, but even with it, are withdrawing every day. So if they take the dose in the morning, the next morning when they wake up, they may have electric zaps, they may feel some of this nausea or muscle ache, and that goes away within an hour or two of taking it. Effexor and naproxen, Paroxetine, Paxil have the highest rates of withdrawal effects, so it's more common of them. It's more severe and unpleasant with them. Jumping back into what this study with Davies and Reed showed, and it was a meta-analysis, including several of their own previous analyses. Their claim was 56% of people on these SSRIs or SNRIs had withdrawal symptoms. And although they did acknowledge the studies they looked at varied from 27% to 86%, which is an incredibly variable rate. And of those who had withdrawal symptoms, 46% of them rated them as severe. There was a widespread overrepresentation of people having problems or withdrawal from venlafaxine or Paxil. So if you pick the two worst samples of the law, and I'm not saying they selectively pick these two samples, but if they're trying to get a picture of how common withdrawal effects are with SSRIs in general, and they see that there are substantial overrepresentation of these two bad actors in the law, right there you would say that their overall numbers are overrepresenting the likelihood of SSRI withdrawal problems in the general population of people taking SSRIs. So a much bigger flaw of their study is that essentially they looked at three big studies combined with a lot of little studies. There were lots of studies they discarded because they were transparent in their choosing what studies fit their meta-analyses. Three big studies were all online survey questions where they solicited people who were having problems with antidepressants to find out whether they were having adverse effects and whether they were having withdrawal effects. So to pretend in any sense that that's a representative sampling does not seem a fair representation. And they even address the point that dissatisfaction bias, so what I'm talking about is people are unhappy, who are grumpy, spend lots of time online complaining about their problems. That doesn't mean problems are particularly common in everyone taking that medication or using that approach. They dismissed that dissatisfaction bias could be a problem because, they said, the majority of people who answered those studies actually acknowledged that they got benefit from the antidepressants. But in no way does acknowledging that you have gotten some advantage or that your depression was treated from it mean that your overall assessment isn't negative and that you're spending lots of time online complaining about how bad the medication was. So the other types of studies that they included, several of the studies were case series of people who were being reported just because they had this unusual. Some of these are from the early days, the late 90s of widespread SSRI use, but a case series of 10 people who had problems with Paxil. And the article is clearly written in the spirit of, here, I'm bringing up a bunch of case examples to show the extreme, the outlier, the worst case I've seen. And again, these were medical centers who were seeing large caseloads of people. There is absolutely no way they were trying to be representative of last 100 people I've treated with Paxil and how they responded. They were specifically picking populations who had had particularly bad effects. So again, using those, it's informative to point to the existence of bad effects. It's completely useless in terms of giving us any valid information about how common withdrawal effects or how bad they are. So the other measure that they touted is that, again, of those who had withdrawal effects, almost half of those, which is close to a quarter of the population at large who had stopped antidepressants, that their sensations, their feelings, their withdrawal symptoms were in the most severe category. But for some of those people, the only option they had to check was, were your symptoms non-existent? Were they mild? Or were they severe? There's almost no documentation of severe in terms of permanently damaging, disabling at a physical sense. I'm not denying again that some people are quite distressed. I'm not denying that some people, and again, from what I've seen, a very small percentage of people are in so much emotional distress or physical distress that they can't work or do other household duties or social obligations. So some of the other scales are just dependent on number of symptoms you checked off, and which I don't think one measure, it's a measure of severity. And in terms of how impaired these people are, I don't think it's a particularly accurate measure of severity in that regard. They looked at people who were both abruptly stopping, who just stopped at cold turkey, and who tapered off. But the tapers were usually 2 weeks. Some of them were 4 weeks, including one that claimed to be the slowest taper possible, and it was less than a 4-week taper. So part of what I think why I see such lower rates of problems over the 30 years I've been looking at people stopping these medications is because one of the other things I was taught in training, and I'm still trying to find more studies that have supported this. So I was taught that there are 2 different reasons to taper off antidepressants when you're ready to stop. Number one, and it's, as they framed it, was the trivial reason of withdrawal effects. Number 2 was a number of different studies with a number of different agents indicated that there is a lower rate of relapsing, of falling back in depression, if you tapered over at least 6 weeks versus either stopping abruptly or a short taper. And in all these studies, the increased rate of falling back into depression wasn't in the first 1 to 3 months, where relapse and withdrawal could be confused, but it was from 3 months out to 12 months out. And it wasn't a huge difference, but it was at least 10 to 15% higher of the rate of falling relapsing compared to the people who stopped quickly. Now, I'm having trouble finding a number of those studies, and part of it is because almost none of those studies were studies that were explicitly or only designed to look at how do people do rapid taper versus slow taper. They were more often describing course of treatment of people with this. And one of the side phenomena or minor aspects of the paper was, again, this difference in relapse rate, or some would call it a delayed rebound. And you are more likely to rebound into depression in the following year if you stop really quickly. When I've worked with my patients, I've always recommended a slow taper, aiming to lower the rebound rate. But again, I think that substantially lowered the likelihood I would see of severe and significant withdrawal effects. One of the other topics that this is tied in with is that there is certainly the potential of confusion for what is a withdrawal effect, what is a relapse effect, what is, again, the symptoms that the person had originally that were being suppressed by the medication showing up again. What's a recurrence of the depression or anxiety? What is withdrawal itself? Again, some of it, we can look at the time course after stopping. Again, I am not discounting the history or validity of some people who've had horrible responses to stopping their antidepressants. I would think that we should always aim for at a minimum of 6 weeks. Very often, I'm doing it over 2 months just because prescriptions in the US through health insurers usually want to pay for a month at a time of a given dose. So if you could cut the dose in half 1 month and then order it the next month, then very often people can stop after that. So have a healthy, happy week, and I'll be back next week.